Welcome to the Love and Victory Show with Val, the place to laugh, sip on a little wine, and have open and honest conversation. Here you will find the tools to resolve real life issues. Unwind, pour up a glass, and get ready to exhale. Hello, ladies. Welcome to the Love and Victory Show with Val. I am so excited to have this candid conversation with these two phenomenal ladies. And this is part 2 of letting go where you're uncomfortable. You're having that conversation, that uncomfortable conversation about the almighty natural thing, and that is sex. For a lot of people, it's just especially women of my age group, we tend to not want to have that conversation because either someone's going to look at us like we're being too loose, or they're going to look at us like, oh my God, I can't believe you said that. But there are a lot of questions that goes unanswered because we're afraid to ask. And so today's conversation is going to be with licensed professionals that are going to be able to dig in and help us have this difficult conversation. I really don't think it's difficult. Let's just have it. Dr. Viviana was supposed to be on, but unfortunately she was part 1. She's not able to be here today, but we're going to just take it and do what it do. So I want you ladies to introduce yourself. Tell the people who you are and where you practice and where do you practice at.
So I'll go first. I'm Dr. Kourtney. I am an integrative, functional women's health expert. I also specialize in menopause. So, this conversation that you guys are having is definitely appropriate and definitely right on time because there are some issues that you can face in the perimenopausal transition and the menopause transition that affect your sexual intimacy, that affect that aspect of your relationship with your partner. So it's definitely something to talk about, but I definitely agree with Valerie that it's a conversation that we should just have and stop poo-pooing it and stop kind of skirting around the issue. And let's just talk about it. So my practice is in Houston, Texas. I also see patients in Virginia and I consult across the U.S. Most of my patients are virtual. And I also offer online programs. So that's me.
Excellent. Okay. All righty. Next.
All right. My name is Dr. Mamawah Bourque. I'm a physical therapist. Primarily, I treat pelvic floor physical therapy, so pelvic floor dysfunctions, which sexual related pain is one of the things that I typically treat. My practice is here in Houston, Texas as well, and I partner along with Dr. Viviana Coles and a lot of other psychotherapists to treat just sexual dysfunction, pelvic pain, abdominal pain, endometriosis, and just a myriad of things related to sex, as well as pregnancy, postpartum, and a few other, anything related to the pelvis I treat.
So you've introduced yourself to the audience, and now we want to just dive in there. What is the driver for men and women? What are some of the drivers for men and women that are struggling with sex or sexual relationships with their partners? Or is there any drivers?
I can go first. Just speaking on, typically speaking, women have a more intimate experience, emotional considerations when it comes to sex, while men, although there are men that do have it as well, there can be that is not necessarily the driver with men. And so at times, there's a discussion or a concern for a lot of my patients that are women about just jumping straight into intercourse, whether it's lacking foreplay, and even how much foreplay can have an effect on pain with sex, because you need that stimulation to even just be more lubricated. And there's sometimes people are just needing to know that sometimes is necessary.
Well, do you think that that's because for men, they work, and Dr. Sims, please at any time jump in. Do you think for men that they lack that need to have the foreplay where a woman does because she needs to have more of a work up to it, and a man is, or does a man need it?
I mean, I think that everybody could use foreplay. I mean, I don't think that men poo-poo foreplay either. I think they probably enjoy all of the aspects. But if you look at the data, right, and even if you go back to the traditional or the groundbreaking Masters and Johnson study, when you looked at intimacy and arousal, although everything in that study design was probably not ideal because there was a certain amount of bias built in terms of the women who were willing to do that research. And if you look at that model, I would honestly say that the sexual drive that they kind of uncovered in that model is more in relationship in terms of arousal. Is in relationship to men, because the men don't necessarily require as much intimacy. That is not necessarily what triggers the act of physical intercourse. For women, if you look at more recent models, they really do show that intimacy is the main driver in physical intimacy when it comes to women. So they really do need that intimacy time. That's why a lot of times you'll see patients who say, we don't spend enough time together. We don't have date night anymore. We're always on the go, or I'm busy and stressed about other things. I can't relax. All of those things affect your ability to build intimacy, right? And it's really that need for intimacy that women crave. And, it's almost like once you get into that space where you're feeling more intimate with with your partner, you're feeling closer, then the physical intimacy is lagniappe, right? And, it's extra sauce on the side. But it's really the mind mental intimacy that women really crave in terms of starting that physical process towards intercourse. So to her point, foreplay is extremely important, and not just foreplay right before the moment, but I always say foreplay throughout the week, right? Like not, foreplay in the morning when you wake up and, while you're at work, and a little text or a little call, something, it's not just like right before that moment. And that really helps to build that intimacy between men and women.
Okay. Taking that conversation a little deeper, we want to talk about those that are a little younger, because I got to go there and then work up to the more matured women. Those that are a little younger, that are a little more free-spirited. In either one of your practice, are you finding that they're coming in with more issues because they're starting off a lot younger having sex?
I mean, I'm not seeing, I don't know about her, but I mean, I'm not seeing that in my practice. I mean, most of my patients, I do think that it's important for you to have an open relationship with your gynecologist, for you not to be afraid to talk about your intimacy life with your gynecologist, because, everybody's intimate life is different, right? Who you choose to be your partner, what activities are stimulating to you, which activities you want to engage in. Those are all different per person. And certain activities, yes, they should come with maybe some additional frequency of screenings, or they may come with some additional questions. But really, patients nowadays are very well educated. The internet is not always a bad thing, and so a lot of patients are pretty well educated as to what they should be screening for, what they should be looking for. But I think it's just important to be open, open about that aspect of your health, right? Because I do consider like your sexual health like the fifth vital sign as a gynecologist.
I guess my question is, do they really even think, again, I don't want to sound like a prude. Is it a prude or a prune? Or a prude. Okay, I don't want to sound like one of those, but I guess I want to ask because I have grandchildren. And I want to ask young adults, are they coming in younger with They're not. Okay.
If
So
you
the
look at the
ones that are
statistics,
younger, they're more
they're more educated. They're actually a little bit more conservative, I would say. If you look at statistics between, millennials, right, and older generations, whether or not that has to do with the availability of information on the internet, I don't know. But statistically, they tend to be a little bit safer.
So my question is, and I'm glad to hear that because what we had growing up was not, we didn't have a lot available to us as a young adult. And so we kind of had to talk to our girlfriends or figure it out. So what I'm hearing you guys say that it's just more available for them to do their own research online. Or they're more open to having that conversation with their physicians or with someone that is a little more knowledgeable about sex.
I think that even for me, most times whenever people come to see me, they don't have a problem speaking up or talking about their bodies and understanding their body and their sexual health. But I will say that a lot of times what I find is that people don't know their body, meaning like, I don't know what my vulva is. I don't know that I have.
What is? See,
the vulva.
I don't know.
Like the entire
vulva?
space.
Educate me. Tell us, the people in the back of the room, what is a vulva? Yeah, the people in the back of the room.
So the vulva is basically the entire female genital area. So the vagina is the entry point where typically sex occurs, but the vulva is everything encompassing. So your labia, the inner labia, the entire space. And so, I tend to do a lot of review of just understanding and knowing your body so that you're able to know when things are different or changing, and you can be more in tune with sex. Like if you know where your clitoris is and you know how to stimulate your clitoris, and what that does to your body from an arousal standpoint, from an orgasm standpoint, it brings you more in tune with sex in a more, I don't know, direct way instead of this indirect thing that's just occurring to you. It just brings more awareness and in tune with it. Even my younger ones, they sometimes have no clue.
To piggyback, I totally agree. They're totally open, but I think, foundational education of the basics of anatomy, that is still lacking despite, the internet and all the information that's out there. And I do think that it's important not just to know external anatomy, right, but also internal anatomy, trying to positions and using pillows and using aids. I think these things make a difference in terms of the exploration of your body and what ultimately is going to be most pleasurable to you. If you only do the same position or two positions or three positions and you never experimented outside of this little box, then there may be another position that really works better for you, that gives you better pleasure, better sensation, but you won't know that if you're not willing to kind of color outside of the lines.
Okay. Mm-hmm. Okay. Well, let's talk about it. Have either of you guys treated patients with disabilities?
I have.
I would say, I wouldn't necessarily call them people. Yes. Absolutely.
Yes. Well, and the reason I'm asking this is because, as I shared with you guys, I have some questions that specifically they want answers for. And on the Love and Victory show, we have a candid conversation. It's always respectful, but we try to get answers we get questions answered that they want to hear. So one of the questions that came, if someone, let me make sure I'm saying it right. What is the percentage of patients that have disabilities that come to you about sex? They just came straight at it, right?
From my perspective, but it's a relatively small percentage of our patient population. So, if I had to put a percentage on it, I would probably say it's relatively small, definitely less than 5 to 10%. Whether or not, but do I think that that's reflective of the amount of patients who would like to talk about it or willing to talk about it? I wouldn't necessarily say that. A lot of of times when I'm seeing my patients, they may be there with their caregiver, or they may be there with whoever brought them to the appointment to help to assist them. And I think sometimes that can pose a barrier in regards to them really being vulnerable about what questions they might have to ask about that area of their health. But I would say from my clinical experience, it's been a relatively small percent.
And for you?
And for me, I would say mine would be a little bit more than, but that's only because of what I do. I'm a physical therapist. So most people come to me because they have a disability. So disability varies from something physical where, like, for instance, if somebody had a stroke or spinal cord injury where they are not able to use their body, they have to use more mindfulness sometimes for arousal. And I have patients that have, a physical disability. Then you have people that have something that is just less visible to the naked eye, whether it's like a sexual trauma, whether it's they've had just a lot of internal surgeries that have caused them to now have different physical dysfunction, hip replacements.
So how do you guys advise? So you have a patient that may have some challenges. You have a patient that may have some challenges of male or female, and you could have male or female, correct, in your practice. And they shared with you, I'm struggling in the area of intimacy with my partner. What do you think I should do? How do you handle that? What type of, how would you start? How would you advise them on that conversation, with that conversation?
Well, for me, every person that I speak to, we talk about sex.
Okay.
So I'm asking them questions about, are you having pain with sex? Are you having pain with before? Are you having pain with arousal? Are you having a difficult time maintaining an erection for my male patient? Do you have pain after intercourse? Is there a certain position that's more painful?
I'm very similar. I start with a basic history. Of course, my practice is primarily women, so I'm not necessarily asking about erection health or whether or not they are having issues there. But I do start off with a basic, health history. I ask every patient in regards to, how do they identify, what their partner preference is, because different health conditions occur in different patient populations. So I want to make sure that I'm knowing my patient well, and what issues they may be facing. You do definitely ask about, how happy they are with their sex life, if they're having any issues with their sex life or any concerns that they want to discuss about their sex life. All of that is part of the basic intake history.
Okay, and it's back to the male. You said the arousal part. Do you think that they struggle a lot with that in secret or in private because they don't want someone because I guess the word I want to use, and guys, please help me, because men are so primitive. Please, if anyone's listening, I'm not trying to offend anyone, but they can be primitive. Do you think that they struggle in secret because they don't want someone to know that they're struggling in that particular area? So they, even with their doctor, having that conversation with arousal?
I think that there's a lot of times just a lack of knowledge that there may be things that are impacting their ability to be aroused. For instance, blood pressure and cardiovascular system plays a big role because that's flow. Like blood flow is what causes the erection. So if you're having some circulation issues, that could be something that might be the reason why you're having a challenging either getting an erection or maintaining it. There's also weakness in the muscles inside the pelvis, which are the things that I work on to see if there's like an inability to contract that muscle, because that's going to impact the strength or your ability to maintain an erection as well. There's mindfulness, just like men can have mindfulness issues too, where they just kind of check out of it because of everything else going on in their day-to-day operation. So, and some don't even know it can be treated.
One of the things that I have noticed when it comes to female and male, we all have our own struggles, and we tend to not really, we suffer in silence until we get to a point that we're ready to have that conversation. So I think that suffering in silence, let's talk about suffering in silence on male or female side, and how long you've seen patients do that, suffer in silence.
I mean, from my perspective, I think that women can suffer for, months to weeks to years. A lot of whether or not it's who they feel comfortable with, whether or not they're disclosing that health history to a provider or to a confidant that could refer them to a source where they could start to learn more, reach out for provider resources, reach out for therapy resources, pelvic therapy resources, sex therapy resources. It really, from my experience, it really comes from you getting comfortable enough with yourself to either ask those questions, or it's presenting such a big problem in your life that you feel like you don't have any other choice but to address it. That's what I usually see.
Yeah, I agree. I agree. It's usually it's a myriad of things, and like you mentioned, I think any of these resources, like figuring out all three areas, sex therapy, or relationship therapy, physical therapy, and just going over your diagnoses, your medical history, can all impact sexual function.
Okay, one of the things in my day, we would go, and you please correct me if I'm wrong, I believe that a male physician, a male patient will go to a urologist if they're, yes. And so for me, this is very enlightening, because what I'm hearing you say, you treat male and female, correct? Mm-hmm. And so therefore, I didn't hear you say you're a urologist. And so can you please kind of enlighten us on your profession and really what that profession is, and how does it marry up with the urologist?
Okay, so the words I always use to describe pelvic floor physical therapy is, it's the therapy you didn't know existed for the symptoms you never could explain. So a lot of times that there's people that are kind of like, I've got pain, or I sneeze and I cannot sneeze without, I can't hold my urine when I sneeze, and I've always experienced pain with erection, or I've always experienced pain with intercourse. I just thought that was the thing, like that's what it was supposed to be. I generally treat the whole body. It's more of a holistic care because there's mindfulness included, but there's also physical dysfunction. So I assess the stomach, what's your breathing patterns, from your muscles that are inside your pelvis. They move just like the muscles in your arms and your legs. So they're skeletal muscles, so you should be able to actively move them. Some people, it's not about getting them stronger. Sometimes it's releasing those muscles. Because just because you can get tension in your shoulders, you can get tension in those muscles that might be contributing to the pain. And people don't know that.
Well, I think that this actually is so enlightening for me. So I'm sure that there are people out there that really are needing to hear this. And when I think of you, both of you all, both of you all practice with holistic, the whole body, a more natural. And I think that if we go there, and especially this generation, it's the generation that we're in, we're looking for more natural. In this day and age, we're looking for more natural ways to treat versus medication. Because medication, in my opinion, is a temporary fix. And I'm not knocking anybody that has to write a prescription, but I'm not going to stay on a prescription long. I want to fix my body. I think it's even hard for me to even just start to take a pill. So I'm going to ask you, Dr. Sims, if I came to you, of course, menopause, what age group is menopausal area? What does the age look like?
The average age of menopause is 51, and you can start going through your perimenopausal window and us not consider it premature or early anytime after 40. So 40 or older, you can start to go through into your perimenopausal transition. I do have quite a few patients who start going through their transition earlier in their 30s. That's considered premature, but that does happen. So if you are experiencing hormonal symptoms, especially, in regards to this particular topic with intercourse, you're looking at things like vaginal dryness, decrease in libido, decrease in energy, fatigue, mood swings, hot flashes, night sweats, all of those things. If you're having those things happen in your 30s, along with, maybe some irregularity in your cycle, you should think about getting your hormones checked. There are physical changes that happen to the vagina once you start going through this transition that can lead to dryness, that can lead to irritation, it can lead to increased incidence of bladder infections. And of course, if your vagina is irritated and dry, and there may be some decreased sensitivity in there as well, secondary to the lowering of estrogen levels that happens through the perimenopausal transition, then the act of intercourse itself can become very uncomfortable. And so, of course, nobody is going to be having any fun times if it's uncomfortable and painful. Like, it's not going to be good.
It's not going to happen.
No. And then I have another group of women who maybe they haven't had a partner in a while, right? And they start going through their perimenopausal transition and they haven't been active in some time. And then what I kind of always remind patients, especially if I'm doing their annual, I'll try to clue them in on whether or not they're having or showing any signs of atrophy and talk to them, even if they're, not on systemic therapy for any other reason, maybe talk to them about some vaginal moisturizers or lubricants or, even vaginal estrogen therapies to try to help to maintain the pH, to maintain the rugae, because I always say, even if you're not active now, unless you're telling me that you don't want to ever use it ever again until, like you go into the grave, not using it anymore, then you need to maintain. Maintenance is important.
You need to take
don't
care of
want
that.
the first time to,
So
rip it open.
You need to go get an oil change every so often. Get yourself together.
Well, yeah, it helps, but I mean, to this particular point, this is just basic maintenance, right? Like, even when you're not sexually active, it's a good idea for you to maintain lubrication, to maintain your rugae, to maintain that area, because once you go through the perimenopausal transition, about 60 to 70% of women experience that physical change, right? Decreased lubrication, decreased rugae, which leads to atrophy. So think of it as, I always say, you can revirginate yourself.
I'm not going to stop y'all. I'm not going to stop you. I know it's all true, but for us in the back of the room without a medical degree, you get to talking about a Rubio's and Rubik's Cube and all that other stuff.
So folds.
It's like,
the folds. So like in your vagina, you have folds that are maintained when you have good levels of estrogen, right?
Okay, my good Judy's out there. Y'all see how I had them to break it down for us. We need to understand it.
So you got to maintain. You need to maintain your folds. You need to maintain your juiciness. Okay. Because if you don't and you let it dry up like a desert in Palm Springs, when you go to Miami and you meet somebody and you want to have fun times,
it's not going to be fun.
It's going to be murder scene in the bed. It's not going to be fun.
Yep.
Mm-hmm.
I think it's super important to, if I could add on that, I love that Dr. Sims mentioned lubricants, because I think people have also would really benefit from understanding the different types of lubricants out there. And today's lubrication options are not back then lubrication options. They're not yesterday's. No. So much more. And there's so many good ones that are going to maintain your pH, and they're not going to irritate the tissue.
Look at the osmolality. Those are important things you want to look at.
I'm loving y'all. You know why I'm loving you guys? Because you guys are so transparent. And we as women are so uncomfortable. Well, we can be uncomfortable with having this conversation, but it's such a needed, and you guys are doing it so tastefully. but it's still raw. And I love it because we need to have that conversation. And I want to step into and I know they're trying to make me cut it, but I'm not. Anyway, they have to edit it and figure it out. But I want to step into the pain side, because a lot of women really, really struggle once you go through the menopause or as you age. And then there's some that haven't went through the menopause age, where it's just very, very painful. And so they make a decision to just, I don't want to have sex. I don't want to do it anymore because it's too painful. First of all, what causes so much pain in that area? Let's talk about that.
I mean, I think personally, the pelvic floor therapist should take the floor on this one.
That's exactly where I was going.
That's exactly
where I was going.
Not enough people engage the use of a pelvic floor therapist. I mean, again, if you look at the evidence and you look at the statistics, a lot of people will go and they'll get a surgery trying to correct pain, and it really is an unnecessary surgery. It's something that could have been corrected by pelvic floor therapy. And this is not just me, Dr. K, saying it. These are stats.
Yeah,
so if you're having pain,
Dr. Sims, you said you was gonna let her take it. Let Dr. Bourque have it.
You're doing a great job, Dr.
So for people who are listening, they know, and they should be thinking, okay, if I have pain, I need to be thinking of 2 appointments. I need to be thinking, okay, let me go see my gyno, to make sure there's nothing upper, not in the pelvis that's causing the issue, but also let me call my pelvic floor therapist and get a referral. Or if you've been referred for a surgery for pain, have I gone to the pelvic floor therapist?
Okay. Yeah. Okay. We're going on.
With that, I will release the flow.
Well, you did that, honey.
You did a fantastic job. That was a great lead-in.
Yes. So come with it.
I 100% agree with everything she says. We are the one, like I said, we treat things that you didn't know could be treated, and we do not use any medication to treat it. We are physically treating your body. And so you asked that question about the why before. I want to know the why. We dive deep into the why. One, because, we don't necessarily have a license to treat from a medicine standpoint. But on the same end, a lot of these pains that people experience may be related to muscle. The fascia, meaning the thin layer between the muscle and the skin, that may be scar tissue. So, for instance, if you've had a C-section, if you had a surgery on your gallbladder, if you had a surgery on your abdominal, like you've had intestinal surgery, or even if you tore during birth, or hysterectomy, endometriosis, where your body is like basically the lining of the inside of your uterus. What should be inside where your uterus lies is growing in different areas, and that could attach to other organs or just other tissue. So we look at what does that feel like, and then we treat both internally. I treat both internally and externally. So I can see what your stomach is doing, see what things look like from the outside, and then inside as well, see where your pain is by assessing, what happens when I push here? Now, what happens when you bend your knee? We work on breath, because breath is associated so strongly with how the pelvic floor moves. So I retrain people how to breathe optimally, not necessarily better, but optimally, so that you can have movement happen down there, because that's what makes movement happen. So it is very in-depth. Yes, I would say that we are the experts when it comes to muscle pain in relation to the pelvis. But we know when to refer out to when we're like, something's not right. You need to go see your gynecologist.
Keep in mind that sometimes what's going on, I always say what's going on in the mind and in the energy and in the emotions will show up in the physical body. And so if also, again, this is not just Dr. K, but these are stats, there are, you have higher incidence of things, anxiety, depression, trauma, all of those increase chronic pelvic pain. So you can't just always think about, have I had physical trauma in that area? You also have to to think, have I had emotional trauma? Have I had, mental imbalance? Am I experiencing a battle on that front as well? Because it may not be showing up in any other area other than my pelvis, other than my physical body. Those fascial layers that she was talking about can hold tension in terms of your emotional energy as well. So it really is your pelvis. I always say as a gyno, your pelvis is like the Mississippi. Everything run downhill. All your drama, everything in every other system will show up in your cycles, in your hormones, in your pain, in your fertility. All of that is reflected as a woman. So it's just important to think, right? Not just about the physical traumas that could happen that maybe want you to think, okay, I should be thinking about pelvic floor therapy. That might be a component of why I'm having the pain, but also mental as well.
And that's why psychotherapy for me, I really think psychotherapy plays a really big role, because there's some times when I've seen people and we've made the things that were a problem better, but they're still not able to experience sexual intercourse because of something. And in those moments, I'm like, I don't want to wait till then. Honestly, it should be in conjunction with, in many cases. But psychotherapy, seeing a sex therapist or a relationship therapist can help you address those elements too. So that
there can just be so much trauma, right, in relationships. And as women,
God.
You can store a lot of that trauma in your pelvis. There could have been emotional trauma in a previous relationship. There could have been physical trauma from a previous relationship. You might have never been satisfied physically in your previous relationship, and you're holding that tension in your pelvis. It's just, it's so many things.
Let me tell you, ladies, you guys have, y'all are on it. And I tell you, now it has to be a part 3 because they're going to get sick of me. Because I think this here is so, we really have to have this conversation because I'm sitting here as a young 58-year-old, I don't want to tell my age, but I'm sitting here learning so much. And things that you would think that I would have already known. And I keep telling y'all, we're going to the back of the room. The people in the back of the room, some of it's me, but I do think that this conversation is a conversation that has to continue. I'm going to ask you guys, I have 2 questions I'm going to ask because I'm sitting here with 2 beautiful African-American women. And for me, health and pain doesn't just start and stop with one race or another. But because I'm sitting here with 2 beautiful African-American, highly educated women, I'm going to ask you guys, what would you say is the biggest struggle for us as African-American women sitting down having this conversation? Why do we struggle, or do you feel that we struggle with having this conversation?
I would say I do think we do. I think they're just generally speaking, from a medical standpoint, I do think that one thing that people typically tell me, my African-American patients, they don't feel listened to when they go to providers a lot. And so or their pain, it doesn't seem like a thing. I mean, even if you just look at the Black maternal statistics, a lot of times people don't take Black American pain. Well, at least this is what research shows, and also what from anecdotally what my patients say. They don't feel believed. They don't feel like anybody's going to do anything. So what's the point? I think that would be one thing that really just holds people back from speaking about it. Another thing might be how they grew up, maybe.
Mm-hmm. I agree with all of that. I think it's definitely an issue with people not feeling like they're listened to, people not feeling validated in the provider room, but also, just extrapolating right to the other struggles of African-American women, it's also, you have to look at access issues. You have to look at vulnerability issues. You have to look at, just like she was saying, in terms of all of the other things that people have to do. And sometimes people putting themselves last on the list. So even though they've been dealing with pain for a while, they're like, you know what? I don't have time to deal with this pain. I got to get up. I got to go to work. I've got babies to feed. I've got babies to drop off at school. No, sex is is not enjoyable for me. No, it's painful, but I don't have time to deal with it. I don't have money to pay for co-pays to go to the doctor or money to pay for the physical therapy. It's just, there's so many challenges I think that can arise in terms of Black women in particular, not feeling completely whole on this particular topic in this particular area.
Okay. And I'm going to have one last question, but then I'm going to ask, I'll come back to that question at the end. How has the overturn of Roe versus Wade impacted African American women or all women, in your opinion and in your practice? Have you seen a change?
Okay. So with Roe versus Wade, I would say its impact, of course, on the African American community is vast, because the reality is our communities, Black and brown women, are affected the most when it comes to access for care. Black and brown women have more difficulty in regards to socioeconomic status for a large majority of these women in terms of access. They cannot always necessarily afford to travel miles and miles, take time off of work, pay expensive hotel bills, car rental fees on top of provider fees. So in all of the argument in regards to, well, there's maternal support centers. Okay, those maternal support centers aren't going to support the child its whole life. Even if you support the baby for a year, okay, what about year 2, 3, 4 through 18? We know statistically it increases poverty in our communities. Let's just call it what it is. It increases poverty in our direct communities, in our circles. So, and then people are scared too in terms of do I have enough birth control? I have women who are scared that something is going to happen with contraception and they're not going to be able to access their contraception even for non-pregnancy related concerns because of the way that the opinions were issued. So, personally, I feel like, from my personal opinion, is that you can be as pro-life as you want for your own individual body. But as an OBGYN, I do not feel like women should be placed in a situation where they have to make a choice that could endanger their own health, endanger the lives and the well-being of the families that are already existing, the children that are already existing. I feel like the only person, I think a doctor very well said it, it's a little crowded in that medical room between the doctor, the patient, and the government. There's just not enough space in that exam room for all three of us. And that is a problem. So yes, that's how I see it.
Baby, you summed that up very well. And of course, with you, how do you feel? Tell us, Doc.
I 100% agree with Dr. Sims. I haven't heard that statement before where you said it's a little bit crowded in here with the government, the doctor, the patient. But yes, I definitely feel like this should be a patient. And we're getting into patient privacy at this point. What a person wants to do and communicate with their provider is now being put on a public stadium, and they're asking everybody to have a microphone to basically say what is going on with their body, and there's no other physical dysfunction or physical issue or physically related problem that you have to speak so loudly about, except for when it's related to your reproductive system. And again, who does this impact? Women.
It's unbelievable.
It has definitely impacted my practice, how I communicate with people when it comes to just your pregnancy. We just talked about Black maternal health. We just talked about, socioeconomic status challenges. All these different elements definitely are impacted by this Roe versus Wade overturning. And I don't know. I know that the future feels very heavy right now across the country, in some areas more than others. What we really need to do is just keep people informed. Knowledge is power. Speak to people about their bodies, encourage women to understand themselves and use their voice as much as we can, and vote.
Not just vote in November. I need you ladies to be voting progressively.
Yes,
Progressively.
literally,
Every
because
election, your city elections, your school board,
your state
your local,
elections.
every single
Local is-
election.
Yes,
I need
local
you to vote your
especially.
voice, whatever it may be. I just need you to get out there and vote it.
Well,
I
I'm going to
agree.
say this here, ladies. I am so honored. I have to cut it because, people be like, golly, all they doing is talking. Well, I know we had some good conversation out here, and we're going to have a part 3. And then Dr. Sims, just having this conversation with you guys, I think we should have on a regular basis on the Love and Victory show, a health conversation.
Yeah, health round table.
We need to have a round table. And I really would love for you two. You guys bring so much energy and authentic. You're very authentic. And I think that for me, it's important that people can relate to you in the conversation, and I just feel safe. I feel comfortable. I feel like I'm having a conversation with my sisters, my good Judys, my girlfriends. And so I hope that the Love and Victory Show family has enjoyed this conversation. And ladies, before we end it, would you like to end it with anything? What would you like to say about your experience on the Love and Victory Show with Val podcast?
I probably my house is about to get super loud, so I will say
they're excited. They had a great time. There you go. That's what I like.
Hold on a second. Yeah, but I really enjoyed speaking with you ladies, and so all my kiddos are coming on in the house now, but we have to do this again soon.
We will, and we'll connect. And you can just
Definitely.
jump off. Go give your babies a hug.
Okay.
Bye.
Bye.
Okay.
And for me, as always, I've had a wonderful time. I look forward to coming back and sharing more health information with you guys. If anybody wants to try to find me, you can always find me at Dr. Kourtney on Insta.
Okay, then we love you, and until next time. Bye.
Bye.
This was great.